And so this is an important concept. If you see a history of frequent job changes, short job durations, these are the people that go on to have problems with somatization, symptomification, delayed recovery, chronicity of illness, right? Keep those things in mind, right? Give them a questionnaire. Get that work history. That'll help you. Okay, next. Always, I like to ask the questions about exposures. Again, I'm not necessarily saying this is your area, but certainly keep in mind that sometimes people could have exposures which could cause some different symptoms. Give them a questionnaire. Let's see what they say. It doesn't have to be your area. Okay, next. Family social history. Okay, now you and I were always trained to do this, right? But the most important thing on this history is you have to look at it carefully. Why? Because on the questionnaire, I will usually ask a question about a personal history of marriage, children, and it's the most important question. Do you have a past history of a poor childhood rearing or abuse? Any difficulties in family relationships? Ask the question. Why? Because in the medical literature, this question, a past history of abuse, is the number one question that predicts patients who go on to have somatization, symptomification, delayed recovery, chronicity of illness. These are the patients who file claims. These are the patients who have trouble in the work environment. These are the patients that you need to know about. Because if you have somebody that has a past history of abuse with vague symptoms, the MRIs don't look that significant. The exam's irregular. Don't, whatever you do, operate on these people. And certainly keep in mind that they're going to have a filter of how they see the world, how they see their illness, and how they're going to interpret it, right? Next, I've given this lecture for years. I've tweaked it through years, depending on the medical literature, but some things have been constant. I have almost always had a patient recently that had a past history of abuse. And by the way, a lot of times they don't talk about it, right? Sometimes, for example, I've had patients where in the family history, they say, father deceased, age 54, I don't know why, or something like that. So sometimes you have to drill on that, right? I say, well, that's a bit of a young age. Did the doctors ever tell you why the person ever passed away? Said something about his liver. Oh, you start to get the opening. Oh, and I will say non-directly, well, sometimes people have liver troubles, could be because they were drinking too much. By any chance, did that ever happen in your home? They say, well, yeah. And then you start getting into, well, was the home ever somewhat verbally difficult where people were yelling or shouting? Yes. By any chance, was there any physical hurting, any touching that was inappropriate, right? And you start to unroll this. You get this from the history. You have to ask these questions. You have to see if it's operating because it's very common in our world. I'm not saying, by the way, that you and I are psychiatrists, right? We're not. What I'm saying is you have to know these things are operating because it makes a difference on how you interpret the results, what impact it has on their examination, and what you're going to do for them or recommend for them, okay? Now, review system, okay? You and I were always trained to do review systems, correct? And it's just a kind of standard form, right? Well, what happens in the claims context, right? Here's a review system, right? This is a dishwasher who's got stressed out. Look at that. Check marks next to everything, right? A markedly positive review of systems is an indication of someone who's got a somatic symptom disorder. These are the people that go on to have these difficulties, right? Give them a questionnaire. Let them document it. Put it in your reports. Put a copy in there, right? And just say, look, there's some over-reporting of symptoms, right? It's going to help protect you. It's going to make your reports more credible. It's going to make it more understandable when you justify your opinions. When you say, don't do surgery. When you say, the outcome is not as bad as they say. When you say, the objective findings are greatly disparate from the subjective complaints. And because I see these markers that are subjective and unreliable, I have to rely on the normal pathophysiologic mechanisms, right? What are you seeing? You're seeing the somatic symptom disorders. And the prior nomenclature was somatoform disorders. And there's all different terms that have been used for this throughout the years, right? And what's the criteria? Okay, so look, there are actually explicit criteria put in the DSM-5 that talk about the somatic symptom disorder. So you can start to see how it's described. What does it mean? How often do they report the symptoms, right? And there's different types, right? Look at this. You've heard of some of these before. A conversion disorder, factitious disorder, psychological factors affecting medical condition, right? These are terms you've heard before, right? And I'm not asking you to diagnose them. I'm not asking you to treat their psychiatry. I'm not asking you to be a psychiatric expert, right? I'm only saying what is operating, right? And if somebody questions you, well, my client said this, and you said that there's nothing wrong with them. You can say, I didn't say there's nothing wrong with them. I said, here's the normal outcomes from that surgery. Here's what the physical exam suggests to me. Here's why I think their impairment rate is this, or they can work, or something like that. But I do think that they're over-reporting symptoms. And this might be a somatic symptom disorder. And that's something that's influencing their opinion, right? Here's a questionnaire, right? So if you think it's operating, you want to give them a questionnaire to document your opinions, to support your substantiation of what you're thinking, then here's something you can see. And you can use that to put it into your reports, or to use in guiding you on how you interpret what to expect from these people, right? Now, this may come as a surprise to you. Sometimes people are lying. Lying, though, requires a whole bunch of things, right? First of all, lying requires the deceiver to keep facts straight, believable, and withstand scrutiny, right? And so that means that if somebody's fabricating things, they have to keep giving a consistent history, a consistent way. Well, it turns out that oftentimes people that get into this, unfortunately, aren't able to do that. And so what you'll see is discrepancies in the records. You'll see discrepancies between what they tell you and what you see in the records. You can see discrepancies between one point of your examination and another point of your examination. You can start to see where the things don't add up, and you see that pattern. And if you see that pattern, it's tipping you off, right? And there's different ways to look at this, right? So the ways that are omitting facts, that's the most frequent, or committing, which means that you're just basically telling a lie, right? And so the most frequent is people forget to tell you, right? So that's why the records become so important, right? And when people are telling you the truth, right? They just give it over to you, right? But when people are trying to deceive you, then they're trying to twist you and convince you and move you in a certain direction. That's when the flags have to go up, right? How do you detect deviation from norm? Well, there's different ways, and there's actually literature about this. And I've actually been to lectures on this. And so just take a look. Look. First of all, you'll see clusters. People will change their posture. They'll avoid looking you in the eye. They'll perspire. They'll cover part of their face. They'll pick at their clothes. There'll be all kinds of things. There'll be a mismatch. I've had patients come into my office, tell me that they can't sit because of their orthopedic injury, yet they sat in my exam room for 2 hours filling out questionnaires. They sat in my office while I took a history for an hour. And that's not true, right? Next, wait for 3 to 5 seconds. What does that mean? What it means is that when people are trying to deceive you, when people aren't giving you a straight honest answer, ask them a question and then wait after the answer. So say, oh no, it's not true. Wait 3 to 5 seconds. If they start shifting around, looking nervous, picking at things, they're showing you the behaviors of deception. Keep them talking. It leads to inconsistencies. This happens all the time. Where you just say, well, tell me about that, right? And they keep going and going, and sooner or later, you start hearing stories, information that's inconsistent, right? Equivocation phrases, right? Increase in the adverbs, right? Using things like, well, if I knew then, what I knew later on, and they're trying to, always kind of shift the history around. Those are the patterns, right? You're going to pick this up in your history. You're going to need to know about this. I'm not saying that you're a psychiatrist, psychologist, or that you're doing a careful investigation. What I'm saying is these are the things that you and I kind of know. We kind of know through all years of training, of seeing patients, we kind of know when we see certain patterns, right? Give them a questionnaire. Look what they document. Look at that behavior. You don't have to come up with the final answer, but you do have to have substantiation for your opinions. I'm trying to protect you so that when you write things in a report, when you give your opinion, if you make somebody unhappy, they're going to come after you, right? They're going to take your deposition. They're going to send you interrogatory. They might put you on trial or something as an expert witness. And you have to be ready for the documentation. Don't let it be, well, I'm so-and-so, and I trained with so-and-so, and I trained in this one. Who cares? Who cares where you train? It's got nothing to do with it. These people have things in their heads. They have agendas. They're looking for money, right? And they might have been injured, and there might be some legitimacy there. But sometimes they take on these other behaviors, which we're talking about. They take on an illness behavior. They take on that symptom magnification. They have a use disorder, which goes above and beyond. And that's what you need to be able to say, identify, articulate, substantiate, and put into the thing. Okay? Deceptive communication. Jacob at the start told me it was Pom Pom Sunday, right? Not Palm Sunday. Okay. All right. So, okay. So rest stop, right? So what we've done so far, we've talked about the important concept of what could be operating the claim, right? What are those secondary agendas, right? What do you and I know from our training? What have we learned? What have we seen? What is our experience, right? And then to document it, right? Malcolm Gladwell, Think Fast, Think Slow, Kalman Tversky, System 1, System 2, just the things we're talking about, where you and I are looking at patterns and trying to recognize those patterns. Give them those questionnaires. Let them put it in paper, document it, and it will no longer be about what you said, right? It'll be, here's what the patient shows, right? All right, so that's some of the general questionnaires. Now let's talk about pain questionnaires, okay? Here we go, right? So pain, generally you remember this, of how it's experienced, right? Where people actually have some irritation, nerve ending, and they will perceive it. Then they'll have an experience with that, but what comes on with it could be a pain behavior, things that people do, how they change things, right? So let's give them questionnaires and take a look. Okay, so here's one. You ask these questions anyways, right? When did your current problem begin? What did you do first to hurt yourself? Where's the pain problem beginning? Since the beginning, has your pain problem constantly been, right? Those kinds of things, right? And so what is that getting at, right? So you and I know that if somebody has an ankle injury, but then they start saying like, oh yeah, but my shoulder or my elbow, something, that's not connected, right? That's starting to show you some somatization, symptomification, right? And how many previous episodes have you had, and when are you previously treated, okay? Take a look at this. Look. How many previous episodes of problem you had? Too many count. Once or twice a month, right? When you start seeing that kind of result, they're not even giving me a number. My questionnaire says, give me a number. How many previous episodes? They can't even put in a number. They have to write it out. That's already telling you. There is good data that says that if you have a history of multiple past occurrences of the same injury, that is a direct predictor of people who go on to have somatization, delayed recovery, chronicity of illness, right? These people are not going to get better, right? Don't think that you're the greatest doctor in the world. Don't think that it's all based on this current claim, this current injury, right? These things are operating. If you get to a double-digit answer in this, it is virtually a guarantee in the literature. There is no chance that they're going to get better. Certainly, at best, you can get them back to some kind of baseline of misery before. But that's the rules, right? Next. How often does your pain occur? How would you describe your pain? Or how often do you have numbness, right? And give them a questionnaire. Ask them about location, right? So it's the right side, left side, both sides. And how would you describe dull, sharp, aching, throbbing, pain, right? Now, this allows you to document their responses, okay? And here's what we get. Here's this dishwasher was stressed out, right? Now look at this. right? Bilateral, head, neck, back, arms, leg. And it's sharp, dull, aching, burning, stabbing, pins and needles. They have their entire body involved in this, right? They have lit up every sensory nerve we got, the C medians, the myelinated, the unmyelinated, you got everything on this one page, right? This one questionnaire. It's telling you that this problem is not in their spine. It's not in their extremities. It's in their mind, right? That's how they see themselves. That's how they're experiencing themselves. That is what their problem is. And it's got nothing to do with the original mechanisms of injury. It's got nothing to do with the MRI shows, the EMG shows. It's got nothing to do with that. That's got nothing to do with it. It happens to be how they see themselves, right? Give them a questionnaire. Get this documented. Get it written down, right? Next, look at this. Pain aggravation, right? So tell me, what makes you better? What makes you worse? What has no effect, right? Give them a questionnaire. Here's our dishwasher again. Look this. Worse, 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 worse. Everything makes them worse, right? If you think that this is the kind of person that you're the best doctor in the world, that all your colleagues didn't know what they're doing, that you're going to make them better, that you're going to be able to treat them, that you're going to be able to do surgery on them, and you're going to touch this person, you're nuts. Don't touch them. Don't go near them. Are you kidding? Right? They're telling you on this questionnaire that they are going to be a problem, right? If you tell me that in your entire career, you've never had one patient that you don't regret, right? We said, oh, I saw this patient, I thought it was this, and I said I was going to do this surgery, or I said this was the treatment or something, and then all of a sudden becomes an albatross around your neck, right? This is how you try to pick up some of those people, right? Give them a questionnaire. Let them do it, okay? Next, pain diagrams, right? So pain diagrams, this is originally from Moody Matheson's work, and you can start to see patterns. Once again, I'm asking you, give them a pain questionnaire, right? Give them the pain diagrams. Here's what you're gonna get, right? Here's the stressed out dishwasher. Now look at this, look. You start getting a halo of pain around the head. See this? And diagrams into every part of the body, right? This is not normal, right? Look at this. This is a university administrative analyst. Now look, see, this person has stuff crawling off the hips, right? Stuff coming down the side of the arms and all this kind of stuff. This is not normal, right? They even made sure I saw the dots, every single individual toe. If you see that, this is telling you, this is somatization, symptom modification, somatic symptom disorders, right? Cognitive illness. Don't operate on them. Okay, look, here's another. Look at this, look. Now this is black and white. Doesn't come out completely perfectly, but this is a patient that came in to me. This woman was on long-term disability, had 24-hour nursing help, right? This woman had every imaginable diagnosis you've ever heard of. Now, you're not going to believe this. I'm going to tell you this. You're not going to believe me. You're not going to believe me. Okay, but I'm going to tell you this. She claimed, of all of her diagnoses, that it also included that she had hypothyroidism and hyperthyroidism at the same time. I mean, it's impossible, right? This woman went up to my staff, right? She took hours to fill this out. She went up to my staff and said, look, do you have color highlighters? Because it's not enough to do X's and O's. I had to understand how the pain was emanating from her body, right? They have blue and pink and yellow, and that's what she filled this in with, right? To let me see how difficult her life was, right? Look at this, right? This is a patient who stopped working at 30 years due to fall. And by the way, this is just a fall to the ground, nothing big, nothing severe. And you see this, this was to tell me that the pain was coming out of the body, right? They were having a California out-of-body experience, right? This is telling you that they're not normal, right? Don't think that you're going to say, well, I'm so-and-so, and I train with so-and-so, and I own a boat. Who cares if you own a boat, right? This has got nothing to do with your boat.